So good afternoon, everyone. Thank you for joining us today. This is Connor with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Adding High Value Through Trauma-Informed Care and Evidence-Informed Paradigm Shift, Part 1. So before we get started, I just want to take a moment to orient everyone to the Zoom system so you know how to participate in today's event. So first of all, upon joining the webinar, you were placed on mute just to avoid any distracting background noises. But we do encourage everyone to participate using the chat box feature. So the chat box should be located on the right side of your screen. But if you don't see it, just click on the little speech bubble icon at the bottom of your screen and it should pop up. And you will have the chance to submit comments and questions for the Q&A portion of today's presentation throughout the webinar. And we do encourage you to submit those questions at any point during today's webinar so that we can get to as many of them as we can. So I'll be collecting the questions throughout, and then our presenters will address them once we get to the Q&A portion at the end. And if you encounter any technical issues at any point during today's webinar, please also chat in and I can assist you with whatever is going on. So just chat in to all panelists whenever you're chatting. And additionally, we would appreciate if you could take a moment at the end of the webinar to fill out the brief feedback survey that'll pop up on your browser once the webinar is closed. So we'd love to hear what you thought about today's presentation and also if there's any topics that you're interested in seeing us cover in the future. And the recording of today's webinar and the presentation slides will be posted on our website, ctechny.org, within the next day or two. And we'll also be discussing some additional resources today during the presentation, and those will also be posted on the website along with the recording. So once again, thank you for joining us, and I'll now pass it along to our presenters to get us started.
Connor, good afternoon, everyone, and welcome to this presentation. I just want to mention a couple of things about this presentation, and then we'll introduce ourselves. But first, I just wanted to sort of point out this is actually part one of a two-part series. And in this part, we're going to provide some information about trauma-informed care for organizational leaders. And then in part two, on October 28th, and we'll give more information about that at the end, we're going to have a panel discussion with some organizational leaders who've actually taken on the task of transforming their organizations and aligning their policies, principles, and practices with trauma-informed care. So again, welcome everybody. And first, introductions. I'm going to actually allow my colleague, Dr. Anthony Salerno, to introduce himself, and then we'll get started. Tony?
All right. Yes, thanks very much, Jim. My name is Tony Salerno, and well, I'm a psychologist by training, but I was really working for the New York State Office of Mental Health for 30 years. And in those 30 years, I spent 10 of them in outpatient services, running a clinic, day hospital, things like that. Then 10 years inpatient, and then 10 years really doing a lot of work around New York State to promote evidence-based practices. And my focus has been primarily with adults. Before that, I was a high school teacher and a guidance counselor. So I've been around a long time. And I'm now with CTech and McSilver Institute at NYU. And I'm also the senior consultant for the National Council for what's called Mental Wellbeing. It used to be National Council for Behavioral Health. And I've done a lot of work in that organization with national learning communities on trauma-informed care. So it's really very exciting for me to be, part of this presentation. Jim?
Thank you, Tony. And my name is Jim Rodriguez, and I'm the Director of Trauma-Informed Services at the McSilver Institute for Property Policy and Research and the CTech. And I've been working in the area of trauma for over 20 years right now. Initially, my first work in this area was after 9/11. Working on a study where we were implementing trauma treatments for children and youth impacted by 9/11. We're going to talk a lot, of course, about trauma today, but both Tony and I see the value in taking a trauma-informed care approach from our work, and we've often had this discussion about what does it take to sort of get leaders and help leaders to make informed decisions about becoming more trauma informed. So that's our goal today in many ways, is to provide you all with information. And when we say organizational leaders, I want to be clear that, we think that leadership obviously can be anything. Of course, it could be executive or senior leadership at an organization, but it could be program heads and program leads or unit heads in programs that also want to adopt more trauma-informed care. So our hope is that today we're going to be able to give you information that will help you make informed decisions about the direction of your organizations or your programs as well. And the rationale. We realize that sometimes many of you may be in positions where you may have already sort of identified some or begun to think about transforming your organization or program to be more trauma informed, but you need sort of the tools and the rationale to present to your boards or to your or the organizational leaders that you work with. So we wanted to provide that information for you. We, as Tony and I will make clear, we have seen the value in trauma-informed care over the years in our work separately. But I think in the era of COVID-19, as we see this mass disaster event impact people's mental health, not only the people we serve, but also increasingly among first responders and behavioral health staff, the need for trauma-informed care becomes even more crystal clear from our perspective. And so we're going to share a lot about what trauma-informed care is and how to help give you, again, the tools for promoting it within your organizations or programs. And these are a few questions we hope to be able to answer for you all today. We're going to start off with a basic understanding of psychological trauma, just to set the level a little bit and make sure we're all on the same page about what we're talking about. But of course, why it's important for behavioral health organizations. And then we're going to talk about some key indicators of quality care and how that equates to trauma-informed care. We're going to share about what the science tells us in this area of trauma and trauma-informed care. And then what are the things that behavioral health organizations can do to adopt a trauma-informed approach? And again, how does that adoption of trauma-informed approaches correlate with quality services? So those are our plans for today. And as Connor mentioned at the very beginning, as we go through this presentation, please feel free to chat in your comments and questions and thoughts as we go along in this training. So I want to start off with a poll question, just to get an idea of who's in our audience and what you come in with in terms of your knowledge and background. The first question is, what describes your current knowledge of trauma-informed care? A great deal of knowledge, B, some basic knowledge, C, just a little, and D, this is a new area for me. Take a moment to complete the poll and give us an idea of who's out there and what you're coming in with. Great. So we have a little variety here. The majority of folks said they have some basic knowledge about trauma-informed care. About a quarter of the folks said they have a great deal. And then about another 16% have just a little, or this is new to them. The next question is that, well, actually, before we go into this question, I just wanted to mention that our goal here is to provide some basic information on trauma-informed care. We're not going to do a deep dive on everything that trauma-informed care involves, but we will discuss, again, some of those quality indicators and how it relates to that. So our second poll question is, what best describes your current efforts to implement changes based on trauma-informed care? A, you've implemented significant changes. B, you've implemented at least one change. C, in the planning stage. Or D, no specific efforts at this time. Take a quick minute. Great. Wow. And Tony, I just want to make sure if you see that you see these numbers, but about 40% of people went with option B, implemented at least one change, and another 15% who indicate that they've implemented significant changes in this area. And then about another 40 some odd percent, or close to 50%, who've indicated that they're in the planning stages or no specific efforts at this time. So again, a lot of variation here. So there are folks out here. It's clear the majority of folks are doing some work in this area, at least in the planning stage, and some doing some implementation work, which is wonderful. So we hope that the information we're going to be providing you today will further your goals in terms of moving towards becoming more trauma informed in this era. Okay, and so very quickly, as I mentioned, we're not going to do a deep dive on trauma informed care and trauma. We do direct you to the CTAC website, because we've done a lot of work in the past on trauma informed care, and then we have many resources and offerings that we've provided in the past around trauma informed care. But very basically, we're going to do a quick overview of psychological trauma. And we like to use this. There are many definitions of trauma out there that we can, but we like this one by Judy Herman. Judy talks about trauma as being events that are she talks about traumatic events as being events that are extraordinary, not because they occur rarely, but rather because they overwhelm the ordinary human adaptations to life. And we like this definition for two reasons. One is that it highlights the important ways in which trauma changes people's trajectories and changes their ability to grow and adapt in life. And then more importantly, we often talk about, and we have a lot of offerings in this area as well, around resilience. And so when we talk about resilience and the importance of resilience, oftentimes we talk about those two topics together. We've talked in the past about having a bifocal lens, one that looks at trauma and one that looks at resilience. And this definition really complements the definition of resilience, which is people's ability to adapt in the face of trauma or severe adversity. And so we use this definition. We also want to highlight the fact that from a trauma-informed care perspective, and we want to be clear about this, that oftentimes the term trauma and trauma-informed care is conflated with trauma treatment, and sometimes even more specifically with the treatment of PTSD. And we want to be clear that from a trauma-informed perspective, trauma-informed care is not about treating PTSD exclusively. It is about understanding the impact that exposure to trauma and chronic stress and severe adversity plays in the lives of people we serve. And oftentimes that can play out in a number of different disorders. Trauma can play a role in people's depression, in people's anxiety. It can play a role in psychosis. It can play a major role, of course, in substance abuse problems. And so, but we talk about the importance of trauma and adversity to understand its prevalence, number one, in our systems, and number two, to understand that having an idea of how trauma impacts the people we serve is a critical first step in promoting care, good quality care, and health, well-being, growth, and recovery. And so how does trauma affect, again, just is very basic for folks, but one of the reasons why trauma-informed care is becoming so popular, we see trauma-informed care in many ways as a movement. And if it is a movement, one of the precursors to that movement is the Adverse Childhood Experiences Study conducted in the late 1990s. And very simply, many of you may be aware of this already, but so I'll do this very quickly. The ACEs study looked at the relationship between childhood adversity that occurs in the lives of people before the age of 18, and the impact of that on health, mental health, and physical health problems in adulthood. They looked at over 17,000 people who were patients in the Kaiser healthcare system. And the findings were dramatic in terms of this relationship between the number of ACEs that occurs and the difficulties that people experience in adulthood. But it's also ushered in an avalanche of research on looking at the policies and practices towards becoming more trauma informed, understanding better the interventions and organizational changes that can be implemented to become more trauma informed, to understand and implement policies, practices, and procedures that are aligned with the understanding that trauma is prevalent in our society with incredible impacts on people's health. And just very quickly, what are ACEs? Well, ACEs, again, are childhood events. In the original ACEs study, they had essentially 3 categories of childhood adversity: abuse, including physical, emotional, and sexual abuse; neglect, including physical and emotional neglect; and then what they call household dysfunction or family stress. And that includes having a parent with mental illness, experiencing or witnessing domestic violence in the home, divorce and separation, having an adult in the home or a parent who was incarcerated, and having an adult in the home or family members who had substance abuse problems. As previously mentioned, subsequent studies looking at ACEs has really expanded our understanding of ACEs and expanded the list of ACEs that people could possibly be exposed to. So another study that was done, for example, in Philadelphia using similar methods, looked at the impact of unsafe neighborhoods or exposure to community violence, or being bullied in childhood, or being exposed to severe poverty, or being exposed to racial discrimination, or being in foster care. And so as time has gone on, there have been additional ACEs that have been added to that original list, and research continues to show that, again, the more ACEs that you're exposed to, the greater the likelihood or the possibility or the risk of adulthood impact on health and mental health. And then, of course, there are other categories of trauma or traumatic events that we know also, of course, impact individuals. And these are the ones that we most often think about when we think about trauma, especially as related to PTSD. So things like catastrophic losses associated with natural events, combat-related stress, of course, life-threatening accidents, or chronic illness and medical procedures. So when we think about ACEs, there's an element of ACEs that include both these kind of traditional categories, for lack of a better word, of traumatic events that people can be exposed to, but also a set of categories that include circumstances or in which people live that expose them to chronic stress and adversity that have the long-term impacts. And then this is just a quick overview of some of the health and mental health impacts of early childhood trauma. Neurobiological effects of trauma, including disrupted neurodevelopment, difficult controlling anger and rage, and regulating emotions. Of course, as we mentioned, PTSD is also very possible, depression and other mental health disorders. So as we look at the neurobiological impact, there are some long-term neurobiological impacts, but disease and disability, this is where the ACEs study was really quite profound in understanding this impact between early childhood stress and disease and disability. It's heart disease, cancer, chronic lung disease, asthma, all of these things are correlated with exposure to early childhood adversity. And again, the higher the number, the greater the risk for these diseases or health outcomes. And then it also leads to health risk behaviors, things like smoking, severe obesity, self-injury, of course, alcoholism and drug abuse that can lead to more difficult mental health outcomes as well, or co-occurring mental health outcomes, multiple sexual partners, eating disorders, and then serious social problems. So there's often a cascading effect of early childhood adversity that leads to things like homelessness, delinquency, involvement in the criminal justice system, unemployment, re-victimization, prostitution. So, and again, this is just a small sample of the many outcomes that early childhood adversity is associated with.
Jim, Jim, I'd just like to share something, with you, on that previous slide. And I hope you don't mind that I admit to you some very guilt feelings that I have. As a recovering Catholic, when I was working with so many folks in the 80s and 90s, I just have to tell you, I never asked about adversity. There was not even a line in our health records that would even prompt us to say, hey, look, it might be important when you're working with adults or in families or others. With kids, it was a little, you saw more interest in that area, working with youngsters to examine the degree to which adverse events may be contributing to some of the difficulties. Certainly not as much as there is now, but in looking at folks who had some serious mental health problems, it just didn't come up. And we were primarily concerned with what was the diagnosis, what kind of meds should you get, and providing some psychosocial support and case management. That was pretty much it. And I think about so many other clients that I work with that I'm not sure if I caused harm, but I certainly did not provide optimal service, because there was that whole area of exploring the degree to which, stressful life events may be contributing to some of the current difficulties. And that was just not part of the picture. And I think it's like so important, that this move towards a recognition that these types of experiences can have profound effects on a person's emotional and physical well-being. That is an incredibly important, concept that, unfortunately, when I think about my own career and working with so many clients, where I just completely missed that, and I feel badly about it. And then once you kind of know this information, it's like now you have like a really, in a way, a responsibility. And then the other issue is, and I know in the next slides that you have, is that this isn't just something that a few people are experiencing. The prevalence is kind of astounding in some ways, particularly among the folks that are served in the behavioral health system. But I just wanted to kind of just share my personal connection with that. And that's why I'm doing a lot of work around trauma as part of penance, if that's okay. I'm just, again, Jim, I'm a recovering Catholic, so you have to appreciate it.
Yeah, understandable. And I think to your last point, Tony, around the prevalence. So the original ACEs study demonstrated that it was highly prevalent in the general population. Approximately 2/3 of people in that sample experienced at least one adverse childhood event, and around 1/4 of them experienced 4 or more adverse childhood events. But of course, in our behavioral health system, in our clinical samples, right? So if you think about clinical samples in our behavioral health system, the folks that come in for behavioral health care oftentimes have even higher rates than in the general population. Again, it may be an obvious point, but to be clear, the rates of up to 80% of people receiving mental health services, outpatient mental health services, have experienced significant trauma. 2/3 of substance abuse service recipients have experienced trauma. And sometimes I think that number feels low to me. 95% of state hospital consumers receiving residential care or inpatient care in hospital systems, almost all of them, right? 80% of the homeless have experienced high numbers of ACEs, and 90% of women incarcerated. And so we know that these numbers are higher in the service systems in which we work, in the mental health system in which we work. And so oftentimes, one of the things that's clear is that we like to say, and going back to Tony's point around the importance and the significance of assessing for and understanding the impact of trauma in the lives of the people we serve becomes so incredibly important, because it is more than likely that the majority of people you work with in our systems have been impacted by trauma and adversity in their lives. And missing that, and we're going to talk a lot more about this as we go through this presentation, missing that can have severe consequences for the care they receive.
Well, Jim, I do think about, like, gee, some of the clients, the people I work with that somehow disengaged in services. I wonder if the fact that we really didn't address trauma-related and adversity might have contributed to that, or folks who just simply were not getting better. And the answer a lot of times is up the medication or try other medication. And then under those circumstances, we didn't necessarily see folks getting any better either. And it does raise for me, gee, I wonder for how many of those folks that we served, and I was in this field for quite a long time, that by ignoring or not being aware of the role of adversity in contributing to a whole host of difficulties, where it was really just ineffective, inadequate, care that folks are receiving. I want to bring up one thing that Renee Jones kind of chatted in, because I know, Jim, you've done a lot of work in the area of looking at racism and discrimination and the stress associated with it. Renee says she didn't see the impact of racism on the list of adverse events to kind of understand as a contributing factor for difficulties. I just wanted to bring that up.
Yeah, no, and to clarify, Renee, as I mentioned, the original ACE study did not have exposure to racism and discrimination in there. Subsequent studies have added that. And as I mentioned earlier, right, there is an association of exposure to racism and discrimination that impacts later health and mental health outcomes. But aside from ACEs research, so I put that in the category of subsequent ACEs studies that have been done. Aside from that, there is a growing body of research that is pretty definitive that the impact of racism and discrimination has, just studying racism and discrimination for those researchers out there who do, and the mental health impacts of it, have shown the same kinds of difficulties, long-term difficulties that the original ACEs studies show. So again, long-term impacts on physical health, as well as mental health outcomes. And so that research is also incredibly rich and powerful in terms of showing that that relationship between the two. So thank you for that question. And we often talk about it, and we're going to talk a little bit later about safety and what safety means from a trauma-informed perspective. And it also means oftentimes culturally competent care that focuses and understands the impact of specifically racial trauma in the lives of the people we serve. But a really good question. But again, and I should say, not only with the impact of racism and discrimination, but again, all of the other ACEs work that has been done, at this point, it is incontrovertible that this impact of trauma on the long-term health and well-being of people is clear. And in many ways, the reason why we're doing this presentation and talking about this is that it is almost to the point where it is a requirement for behavioral health programs, as well as social service programs, child welfare programs, where of course you see a lot of impact of trauma and adversity in the lives of the people that are served, becomes clear. So right now, it's not an issue of the research. We're going to talk a little bit about the research, but it's not a matter of understanding this impact. It is a matter of the will to create programs, organizations, and systems that are trauma-informed to better meet the needs of the people we serve. So as we talk about, so this question, how does adopting a trauma-informed, but let's make it clear. So as I said, so as folks as we go through this presentation, and as you all in positions of power, hopefully in leadership positions, need the tools to sort of make the argument for trauma-informed care. This is why we're doing this presentation, and this is why we're focusing. So we're going to try to answer this question as much as possible. How does adopting a trauma-informed and resilience-building approach improve quality of services, as well as the overall business health of a behavioral health organization, right? That's the question. So the answer, a few things, right? First, the value of trauma-informed care to an organization is the degree to which it advances its mission and improves one or more quality indicators. So just for any organization, being able to improve quality indicators and advance their mission. It can improve the quality of care, but also strengthens the overall health of an organization. And again, we're talking a lot about behavioral health organizations and programs today. But it's actually, and we're seeing in many ways, the TIC approach contributing to improvement in outcomes in virtually every setting out there, not only behavioral health, but education, in the healthcare system, in juvenile and the criminal justice system, in housing services, and actually also in the business community, in manufacturing and construction. There are businesses out there who are beginning to adopt a trauma-informed care approach to promote well-being in the workplace. And so we're seeing its use and adaptation and application in a variety of settings. And in addition to that, so when you think about the impact of this across settings, what we envision and we realize, we are in many ways sort of looking towards a future where an integrated system of care means that not only behavioral health system, but imagine for a moment working in a behavioral health system where if you're working with children and adolescents, where the educational system or vocational programs, social service programs in your community, the child welfare services and providers in your community. And of course, as we just said, even the business community is also trauma informed. And so an integrated system like that across all systems and working with an integrated set of programs and systems becomes critically important to promoting health, well-being, recovery in many cases. And there's also cost savings. We're going to talk a little bit later about the cost effectiveness of all of this.
Jim,
yeah, go ahead, Tony.
I just wanted to respond, looking at this, when I think about all the different movements over the last 50 years that has really been a catalyst for a lot of change, that in many ways, this whole area of looking at trauma-informed care is one of those few efforts that actually is designed to support not only the recipients of care, but the providers of care. And it's like one of those unique findings, one of those critical studies that really broaden the value of a particular concept, not just to the people who are served in a system, which is usually the case. I've done a lot of work on evidence-based practices for adults with serious mental illness. And all of the evidence-based practices and supports for people with schizophrenia was really focused on the recipient of care. But this is one of the few that actually says this has implications, not just for those who receive care, but the implications for those who provide care. That's pretty unique. And I think that's and maybe one of the reasons why trauma-informed care has become such an important sort of approach that is beginning to shift so much of the perspective that organizations have and being able to apply that to the workforce. And I think that's a really interesting, interesting way that trauma-informed care has affected the system at large.
Yeah, and Tony, actually to add to that, again, going back to COVID-19, again, for those of you who are organizational leaders and program heads and program leads, right, you are seeing this, right? We are hearing right now of the impact of COVID-19 and its sequelae and its secondary traumatic effects on staff. And actually, what we're seeing is not only the secondary effects, but the primary effects, right? So many of your staff out there have primary traumatic exposure to COVID-19, becoming ill, having a family member who's ill, or having to work on a daily basis out in the community in some cases, right? So all of these are primary exposures to COVID-19 that affect them. And then, of course, also the secondary impacts of working with so many people who've been affected. So, so again, this particular point in time really highlights the importance of a trauma-informed care. And I agree 100% with Tony. For me, the reason why trauma-informed care is so unique when we think about person-centered care, right? Recovery-oriented care, right? These are all approaches to care. Well, for me, what I think trauma-informed care does, and in many ways overlaps with those other approaches, but what it does is, yes, it focuses on a clear understanding that trauma affects and impacts everyone, not only service recipients, but providers as well. And thinks about how to address that impact, that secondary impact. And so, when we think about quality and quality care and developing quality care, this quote by William Foster, quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. And so in many ways, we're going to talk about trauma-informed care. What are those quality indicators that you can apply to trauma-informed care? But in many ways, it does take that single-minded focus on addressing the policies, practices, and procedures in your organization that are aligned with a trauma-informed perspective. Tony, did you want to add anything here?
No, it's just, that when we were thinking about trying to demonstrate, what's the value of a trauma-informed approach in terms of some of the high priority business kind of concerns. And what we really came to is if trauma-informed care has value, it's because it improves quality, right? That is ultimately, the goal and the mission of organizations, and understanding the relationship between some of those principles and practices of trauma-informed care and how, in what way does it connect to and improve quality? Well, that's like really the major case. So in talking about the rationale for why trauma-informed care can be important, and when we have the subsequent panel discussion from leaders who have decided that they wanted to really adopt the principles and practice of trauma-informed care, their goal was quality. And we'll hear a lot more, about that.
And then just a few more things about quality care. The behavioral health provider systems. Again, we are all sort of work in systems where we are driven by the policies and procedures and practices we develop, the workforce interactions and the relationships between and among employees and consumers, right? So quality care is really about sort of designing policies, procedures, and practices that really focus on that relationship between the consumers of care and the providers of care.
Jim,
and this can oftentimes be complicated by our larger political and economic context that make those interactions oftentimes difficult. Tony, yeah.
Yeah, no, Jim, I just wanted to ask the audience out there, when you think of like quality care, if you could just chat in, what do you think is like the most important indicator that your organization is providing quality? It's providing quality services, because there are a lot of indicators. I'm just kind of curious to know what folks would identify as, if we would ask, so what do you think is the most important indicator of quality in your organization? What would you say? And if you could just chat that in.
Members want to use services. Yeah.
Yeah. So, okay. So I'm seeing retention, client satisfaction, discharge with the most goals met, patient status, genuine compassion and care, no longer need services, improvement of symptoms, building a team relationship, timely discharge, attention and direct communication, good relationships.
Wow.
Stress, addressing the stress level of staff, having universal risk assessments, improved engagement, interest in services, a client focus. So the idea of really satisfaction, people accomplishing their goals, meeting discharge criteria, developing trust and relationships, and a lot really focusing on the experience of the patient here, the client. That's like really, if you have a dissatisfied client, it's kind of like whatever we're doing, we could say, well, we're doing a lot of quality, but if people don't value it and are not satisfied or are not making progress on goals, evidence-based tools, collaborative approaches. For some, it's really if we can just help to stabilize folk, and for other, meeting state required metrics is like, look, quality, we have certain expectations and requirements, and we have to meet that. Okay, so thanks so much, folks. I mean, people have really generated a lot. And so we're going to also be sharing, and Jim will be sharing, some other quality indicators as well. But thank you so much. These are great. These are really great.
It's amazing, and they're coming in pretty heavy. And I do see a number of folks here who are also sort of identifying the needs of the staff as well.
Yep.
So quality indicators and trauma-informed care. So first, as I said, we're going to go through each of these quality indicators. We're going to go through 5 quality indicators that we've chosen that we think are oftentimes, the quality indicators that organizational leaders and program leaders are oftentimes most concerned with. A few things on the limitations of the science. First, just to be clear, there is no definitive study on trauma-informed care across organizations. The reason for that is that a study like that would be so immense and so difficult to pull off. That is, looking at all of these areas, and we're going to talk about these quality indicators, but looking across these quality indicators, studying them, evaluating them in organizations, you would need a vast number of participants and an equally good number of organizations that are all on the same page. So research like this on implementing organizational change is oftentimes very difficult to accomplish, even with good resources. So there's a lot of challenges. And so when we think about the research that we're going to share with you, in many ways, it's pieced together through different studies that have been done around different aspects of trauma treatment, and trauma-informed care. However, we know, and we wanted to provide you some of the science available, because we know oftentimes leaders, you as leaders, make decisions, and oftentimes can use good, actionable empirical evidence to make those decisions. There is a growing body of evidence that the changes to be made need to be made, or are oftentimes need to be made incrementally or anecdotally. And as I said, when we have the panel discussion, we're going to be having organizational leaders share their experiences. And that's going to be a theme that you're going to see around adopting a trauma-informed care approach in organizations. And the evidence oftentimes is more practice-based than evidence-based. In other words, we don't yet have evidence-based approaches for promoting trauma-informed care in an organization, again, for all of the challenges that I already kind of outlined. But when you see trauma-informed approaches, and in some cases trauma-specific approaches, in practice, you see some of the principles and policies also, and the impact on both recipients of care and staff members there. So we often see these principles of trauma-informed care shown through work in implementing evidence-based treatments or practices in organizations discreetly.
Yeah, let me just say something about that, Jim, as well. I've been working with when I was in my senior consultant position with the National Council. So for about 10, 11 years, I've been running these learning communities across the country, and really several hundred organizations that I've been involved with over the last 10 years. And very often leadership will ask, well, Tony, let me ask you, where's the evidence around this? Is there any really good, well-designed studies to demonstrate at the organizational level around the impact of trauma-informed care, especially on things that are really important to us, like turnover, right? Client engagement, basic efficiency of our organization, providing the kind of quality. And, as Jim said, it's really tough to take on organizational, multi-dimensional, interdependent variables in a changing kind of environment. It drives researchers a little nutty if they have to try to manage all of this, and then have control groups, other organizations who are not doing that sort of thing. And there are a lot of factors that influence things like turnover or the client engagement that really go beyond just the issue of trauma-informed care. So we just need to recognize that leaders most often have to make decisions in the absence of a lot of this information. And in my experience, a lot of the leadership, they made decisions not so much because there was a scientific study that said this is going to work if you engage in a multi-year transformational process in the culture of your organization, but really by values. And I'm going to be speaking a little bit more about that a little later on. There's a lot of research on trauma-specific treatments, on how it reduces PTSD and other sort of difficulties. There's no lack of research. There's journals on traumatology, and there's a lot of evidence around that. But when it comes to the organization level, it just becomes very challenging because of the complexity and the changing nature of time and events that can occur in an organization that you can't account for, but comes into play that can influence what the outcomes are. So I think we'll go on to the dimensions of quality now. Thanks, Jim.
No problem, Tony. And so, again, these were some of the areas that we sort of designed this webinar around that we think are critically important. And some of you in your chat addressed some of these dimensions, right? Actually, I should say I didn't see a lot around safety, but one dimension of quality, of course, is safety. That is safety that is promoted both for clients as well as providers.
Well,
Of
Jim,
course,
Jim, can I just say
Sure.
something about safety? You know, when I was running a day hospital, and folks would say, Tony, how's your program going? I say, terrific. And they say, well, how do you know it's so terrific? I said, well, because nothing bad's happened in the last 2 weeks. And oftentimes it's the absence of negative events. In other words, it was safe. That was like really high on my priority. Now, it's not the only important indicator, but the issue of like safety is usually, you know, pretty much a core factor in any service system.
Of course, you have just workforce development, promoting staff knowledge and skills around the work that they do. Consumer engagement, I saw that reflected in many of the comments that people said when we asked about sort of indicators of quality, right? Consumer engagements, service use, decreases in no-show and dropouts, people engaged in care. And then, of course, the effectiveness of services. So adopting screening, assessments, and interventions that lead to positive clinical outcomes. Again, that was a big issue, or some of the chats that people provided a little bit earlier, right? Quality care, right? That people are meeting their goals and getting treatment outcomes that are positive. And then coordination. And this becomes critically important when we're talking about trauma-informed care, care integration and coordination that becomes critically important oftentimes, because many of the folks that we think about when we think about those folks who've been impacted by trauma most severely, oftentimes they are involved in multiple systems. Think about those kids who you have who are in the child welfare system as well as receiving behavioral health care. But also adults as well, who might be in vocational programs and other kind of programs, in addition to behavioral health programs that they're in, right? So there's always that element of care coordination and integration. And so we're going to go through these one by one, identifying, kind of what the critical areas are, a little bit of the science on these, and then what organizations can do. So first, of course, safety is paramount. So when we think about trauma-informed care, safety is one of the major principles of trauma-informed care, and creating safe spaces that are both emotionally, physically, and culturally safe, right? By emotional safety, we mean friendliness, compassionate care. Again, I saw that in some of the chats that people provided earlier. Positive interpersonal interactions, conflict resolution. You could see how important those things in a trauma-informed organization. Because people who've been impacted by trauma oftentimes have difficulties with relationships. Oftentimes that is the driving force, and in many ways the way they were impacted by trauma through problematic relationships in their lives and abusive relationships in their lives. And then, of course, physical safety. Just when we think about that, just the environment, lighting, the comfort of the signage, the level of privacy that they have, the comfort in furniture and temperature. So the physical setting, how inviting is it? How engaging is it? And then cultural safety becomes critically important. As we mentioned earlier, as I believe Renee talked about earlier, right, this impact of racism and discrimination, we see that as also, because we understand the importance of the trauma of racism and discrimination, creating spaces that are culturally safe, right? Respect to dignity, and also understand the impact of that trauma. Oftentimes, people of color and members of other marginalized groups are often disproportionately impacted by various forms of trauma. So creating spaces that are culturally safe. And then, traumatized individuals are especially sensitive to features of the physical environment. Oftentimes they're triggered. They can be triggered by the smallest things that we might not be aware of. So understanding that, and understanding that the reactions that we see among the people we serve might oftentimes be trauma-based. And so, again, safety becomes a critical feature of a trauma-informed care. And then failure to develop measures to address workplace safety can lead to disengagement, conflicts, and incidents that can overwhelm both providers and recipients of care and require administrative oversight. So Tony's point, I'm sure, as an organizational leader, as a program leader, oftentimes, right, those incident reports that come in that you have to then sort of assess and understand and report on, also become a major drag on the system. So for all of these reasons, safety becomes a critically important piece of the work. And as we've mentioned already, right, not only safety for the people we serve, but also safety for our workforce. So, trauma-informed care recognizes that people who are doing this work often have exposure to secondary trauma, right? Talking to people about their trauma, working with people who've been traumatized, working with people who oftentimes become highly dysregulated because of their trauma becomes very difficult work. And we know that again, more and more evidence showing that work often leads to compassion fatigue and burnout. So trauma-informed organizations recognize the need to address the risks of the workforce to ensure their commitment and performance. And then failure to recognize and address these risks is more likely to contribute to turnover, absenteeism, and poor performance. And this is something we are seeing in droves in this era of COVID-19. People are leaving programs, are leaving the professions in droves. And from Tony and mine's perspective, we see that as very much having a trauma component because of everything that's happening around COVID-19. And so as far as the data, right, the data that's available, and again, none of this is specifically around trauma-informed care, but we do know that TIC training people in at least understanding trauma and the impact of trauma in some cases, providing them knowledge about trauma and its pervasiveness and impact, can result in improvements in consumer reported sense of safety. So just people understanding the prevalence and impact of trauma, that is providers, understanding that the prevalence and impact of trauma can decrease. Now, Jennings' work was done by looking at a number of programs across mental health service systems across the country. But in addition to that, the work by Azim et al., sort of thinking about how trauma training, so sometimes specific trauma training. So in this case, it was a treatment for kids in residential care that focused on kind of play therapy and working through trauma and addressing the needs of children and youth in trauma in residential care, reduced seclusion and restraints. In many ways, the trauma-informed care movement was ushered in because of the increased use of seclusion and restraints among people in residential care and inpatient care, because of the traumatizing impact of the use of seclusion and restraints. So that becomes a major outcome of focus. And again, more work on this idea of sort of training people to avoid seclusion and restraint is associated with reductions in use of employee sick time, turnover, workers' compensation, and injuries to both staff and clients, and recidivism in clients, losing clients, right? So we know that oftentimes we see these components of safety and outcomes related to safety associated with improved staff outcomes. And so what can organizations do? Well, again, training staff on trauma-informed strategies to promote physical and emotional safety, including de-escalation strategies. So we know, and in a number of those studies, de-escalation strategies were taught. People were trained to use de-escalation strategies. We can also train support and security staff, administrative staff, security staff who are oftentimes in those waiting areas on strategies to promote safety in common spaces and to promote de-escalation in those common spaces. You can also survey staff and recipients of care about their perceptions of the physical and emotional safety in an organization. And also create work groups in an organization. So identifying people within an organization who want to think about how to make the setting more safe and comfortable for the people that we serve. So those are some of the things that you can do, is just create a work group, identify a core team of folks who want to work in this area to create safer and more comfortable environments for the clients we serve. And these are just a couple of examples of some, these will be available on the website. So after this webinar, we'll have this, the recording of this webinar, the slides, and these resources. But these are just a few tips: creating a safe healthcare environments for patients and staff. So these are some tips for creating a physical environment. You can use these as a beginning point to guide your work around creating safe environments. And then actually many people have put together, and there's definitely organizational assessments and organizational scans to identify some of these key indicators of physical safety within an organization. So you can look at tools. This tool will be available for you, but just the questions that you want to ask around how to create that environment that is both physically, emotionally, and culturally safe for the people we serve.
Yeah, Jim, let me just say something, because most of the organizations I worked with over the last 10 years, usually within the year of their involvement in a learning community, looked at the environment, did an environmental scan, and usually a team, including folks, recipients of care, who would basically have this checklist and go around to all the different parts of the program environment and really identify those areas where either it raised, a sense of discomfort or distraction or noise levels, then having focus groups with clients to just ask, what are some of the aspects of the environment that you find uncomfortable or dissatisfying? And that has been some of the most productive and satisfying work that organizations have engaged in. And the process of just involving those who are recipients of care to reflect on the physical environment as well as the emotional environment. To what degree do they experience that this environment is a friendly environment, that they would recommend that other people who may have needs around mental health or substance use, services, would you highly recommend it, that folks come? You can get a lot accomplished by taking a hard look at both the physical and the emotional environment, and the avoidance of re-traumatizing people. It really can't be overstated. Actually, it's such a critically important piece. So I just want to put a little plug in for this particular aspect of again, quality.
And so the next quality indicator is workforce development. So, in a trauma-informed workplace, all staff have a foundational knowledge of the pervasiveness and impact of trauma and adversity. So Tony and I have done many trainings with programs, and oftentimes programs, and if they don't recommend it, we do. That is, we train everyone. We train everyone from the administrative staff, the receptionists, the security staff, maintenance staff, as well as those frontline clinicians and providers, that everyone has an understanding of not only what trauma is and how it impacts people, but what they can do to promote health and safety and recovery in the programs that they work in. So in a trauma-informed organization, they all understand their roles. The clinical care staff is trained in trauma-informed approaches to screening, assessment, and treatment of trauma and adversity. And the failure to develop a trauma-informed workforce in an organization can lead to clients being vulnerable or re-traumatized, and staff being vulnerable to low confidence and compassion fatigue. So being able to work with trauma becomes so critical. And again, anyone in their role can, quote unquote, work with trauma. You don't have to be a therapist to work with trauma. There are things, again, just a pleasant face at the reception desk, someone who's warm and greeting people, safe security staff who are warm and caring, and looking out for the safety of clients. All those things can play a critically important role. So when we look at the research again, research shows that in many different ways that TIC training can result in positive effects on trauma-related knowledge and supervisory behavior. So oftentimes when we see TIC training, many times supervisors begin, and we talk about trauma-informed supervision, but supervision often becomes more supportive, focused on the impact of working with trauma, as well as developing the skills and effectiveness in dealing with trauma. TRIC training has also resulted in staff satisfaction along 5 of 6 domains of research by Hales, feeling like the work is more efficient, like they're more connected to the organization, that they feel more in line with the organizational mission, the direction that the organization is taking, managerial relationships, and general work satisfaction. And again, these are just TIC training programs like the ones that we do around understanding what trauma is, the prevalence, the impact, and what the principles are around trauma-informed care. And then also sometimes training on specific trauma treatments. and collaboration has resulted in improved morale, less vicarious trauma, and and fewer behavioral incidents. And again, sometimes some trauma-specific trainings, like in the work of Hidalgo, where again, there was an intervention there for youth in residential care. So training them on specific trauma treatments. And then survivors and providers indicated that providers who were trauma informed, so this is more retrospective work, working with victims of primarily sexual trauma, but asking them from their perspective, retrospectively, what helped, what made the services more helpful to you. They reported that having people who were trauma informed, knew what trauma was, knew how to address issues around trauma, would be better would be better at helping patients manage their distress during healthcare visits. So oftentimes, again, a trauma-informed perspective works both for those who around trauma-specific treatments and people who've been exposed to trauma in a variety of ways. And then what can organizations do? Again, train all staff, direct service, administrative, leadership, support staff, and foundational knowledge around trauma. Promoting skills development in areas of trauma-informed engagement, how to engage folks around trauma, how to have those conversations about trauma, how to provide information, and resilience building strategies. Providing training and supervisory best practices, including supportive supervision, crisis debriefing, helping folks to debrief, staff to debrief incidents that occur on a regular basis. And then workforce wellness, implementing workforce wellness plans. Many trauma-informed programs you will see having workforce wellness plans that include, wellness programs, that have yoga programs and exercise programs and other health-related activities that increase the wellness of the staff. And then implementing wellness activities to address workplace stress. So these are all the things that organizations can do aligned with the trauma-informed approach. And then also, at the front end, hiring a trauma-informed workforce. So oftentimes asking workers, so as a prelude to employment, interviewing them around their understanding of trauma, incorporating trauma-informed care in onboarding in programs and in agencies. And asking new hires about their knowledge around trauma, the impact of trauma, and how comfortable and how effective they feel in dealing with trauma. And then also recruiting consumers with lived experience of trauma to join work groups, committees, patient and family advisory councils. So and we're going to talk a little bit more about consumer engagement, but one way of doing that is also inviting folks with lived experience to talk about their take on programs. And so just to sort of move into consumer engagement, empowerment and satisfaction, again, a number of people talked about the importance of consumer satisfaction. Remembering that the reason why this is so critically important is that traumatized individuals are highly sensitive to conditions and interactions that compromise safety and personal control. So engaging folks in understanding their experience of care can be critically important to create safe environments, getting their perspective. And again, oftentimes people with trauma and severe adversity in their backgrounds have been, by definition, disempowered, oppressed in many ways. And so getting them to feel a sense of control and involvement in their program becomes critically important. Traumatized individuals are most at risk to avoid stressful situations and disengage. So again, getting their perspective on what helps to create or promote safety and comfort in their programs becomes increasingly important. They recognize that the policies, practices, and procedures to promote trust and collaboration between all staff and recipients of care is also a critically important piece. And trust and collaboration for people who've been traumatized becomes central to the working relationship that they have with providers. And then of course, as we already mentioned, culturally responsive care, respectful of all people with attention, especially to the needs of people from historically marginalized groups, and understanding their perspective and what their needs are in services becomes critically important. And again, failure to attend to these, to engagement, empowerment, and satisfaction of consumers can lead to no-shows and discontinuation of services and early dropout. So as people mentioned earlier, as they were chatting in, right, getting people in and keeping people in care. You can't do anything with folks unless they're coming to your doors, and creating that space where they feel comfortable and safe coming to your doors is the first step in seeing outcomes, positive outcomes in their lives. And again, some of the research here shows that female survivors of sexual abuse valued providers openly discussing abuse and medical issues. Again, this work is coming out of the healthcare arena primarily, but understanding that having providers, so when you're having medical issues and someone who has a trauma history, understanding the impact of their trauma in their lives becomes incredibly important for their healthcare. So being emotionally available, being easy to contact, and being able to take extra time for someone who's been exposed to trauma becomes critically important, that flexibility in services. And TIC training resulting in a consumer reported sense of collaboration with staff. So TIC training makes people feel like they're collaborating with staff, that they have a more significant voice and higher overall satisfaction with services. That providers trained in trauma-informed care report greater collaboration with consumers. So we see that both from the consumer perspective and the provider perspective. They both feel like they are more involved in care, that there's greater collaboration when folks understand trauma and the prevalence and impact of trauma. They feel more supported by their agencies and a greater sense of self-efficacy. Again, this is on the part of of providers. And then trauma survivors are more likely to trust providers who treated them with compassion and took personal interest in their well-being. And again, we oftentimes think about compassion being that ability to hear people's stories about trauma, understand the impact of trauma in their lives, have meaningful conversations about that, and provide services that help them recover and heal becomes so obviously so critically important. But these are all the sort of secondary effects from becoming trauma informed. And what organizations can do, again, training staff on best practices in engagement, and using things like motivational interviewing and person-centered approaches, shared decision-making, or culturally sensitive practices. And I want to point that out because, again, when we use these terms, culturally competent care, person-centered care, recovery-oriented care, all of these different approaches do have overlap quite a bit. And so many times the principles around trauma-informed care are very much aligned with person-centered approaches. We just believe that also that extra sort of clear understanding of trauma and its impact and how to address trauma in the lives is so critically important to trauma-informed care that distinguishes it for some of these other approaches. But again, they're very much aligned. And so organizations can also develop policies, practices, and procedures that promote reasonable consumer choice and flexibilities in the area of scheduling, modes of treatment, and choice of providers. We know that can be a difficult thing to pull off in an organization, but when it's possible, it creates more inviting and open services for clients to participate in. Organizations can survey clients and get their opinions and complaints and suggestions to improve the experience of care. And then, as we mentioned earlier, recruiting consumers with lived experience to join work groups and committees to think about how to improve services and make them safer, more trustworthy, more collaborative, more empowering. And then effectiveness and clinical outcomes. I'm going to move through these quickly, but the effectiveness of clinical outcomes. Again, actually, this is one of the areas of research that we know a lot about. So there is this, and this gets more in the area of trauma-specific treatment, but not necessarily, right? So when we think about what we know about PTSD and how to treat it and how to assess it, there are many approaches. But here, the critically important part is that sometimes people who've been exposed to trauma do not only just experience PTSD or are diagnosed with PTSD, there are so many other difficulties that they face. So helping people understand that impact becomes important for clinical effectiveness. But yes, identifying and thinking about your intake and screening processes and assessments and service planning, and aligning those with trauma-informed approaches, understanding the role of adversity and trauma in the lives of people, and integrating that throughout intake and treatment delivery. The appropriateness and effectiveness of services is inextricably linked to an accurate identification of the factors contributing to the person's behavioral health difficulties. Oftentimes those discussions about trauma can be critical. Again, you don't necessarily have to be treating PTSD to understand the importance of trauma in the lives of the people we serve. And then a failure to identify the role of adversity and trauma may lead to misdiagnosis, inappropriate treatment interventions, and contribute to potentially harmful outcomes such as client frustration, lack of progress, premature disengagement, or engendering negative beliefs about the benefits of services. I often like to believe that, any interaction I have with clients, I should have pointed out earlier, I am also a therapist in private practice, that much of the work, my job is as much to sort of be an ambassador for mental health as it is to be a good provider and make sure that people have a good experience in treatment, regardless of the outcomes in many ways. But so I think oftentimes, failure to understand the impact of trauma can lead to a lot of these negative outcomes. And then again, this is some of the research, I would say, in the area of clinical outcomes, especially with regards to treating trauma, treating PTSD, treating complex trauma. There's a lot of research out there that's available. So, but again, to be clear, women in service settings with trauma-specific services available have demonstrated better outcomes than treatment as usual for many symptoms, right? So focusing on trauma-specific services, understanding the impact of trauma, can oftentimes have better outcome than treatment as usual that might not have that focus on understanding trauma. Organization-wide increased awareness of trauma, signs and symptoms, and impact of treatment are often associated with the use of evidence-based practices in treatment. CHIC for children of parents with co-occurring disorders associated with better self-esteem, improved relationships, an increased sense of safety when you're implementing evidence-based treatments for trauma. And then we also see reductions in internalizing, externalizing problems in trauma-related symptoms, of course. In this area, again, there's no shortage of research showing effective clinical outcomes, again, when trauma-informed and trauma-specific services are provided. And what organizations can do is train and direct service staff and trauma-related evidence-based screening, assessment, and treatment approaches, offer one or more trauma-specific individual and group treatments. So for consumers, train and expect supervisors to ensure, right? So making sure that there's trauma-informed supervision and that supervisors are also well-trained in these areas and able to bring people along. Design medical records with prompts to ensure that every single client has the opportunity to explore, identify, and address trauma treatment. And also, I should add to that, not just those questions that we ask, but the way in which they're asked. So training people not only in using evidence-based screening and assessment tools, but using them in a trauma-informed way. You can have good assessment tools that are used in non-trauma-informed ways and ways that can hurt clients as well. And then create and distribute psychoeducational materials to increase clients' understanding of the role of adversity in their lives. And then lastly, and I'm going to go through these quickly because Tony's going to talk a little bit about what leaders can do, is care integration. Again, as I mentioned earlier, the importance of care integration is so critical because, again, many people, especially with high exposure to trauma, are involved in various service systems. So failure to attend to specific sensitivities of traumatized clients in their involvement with other community entities can lead to relapse and recidivism. So they lose services. Oftentimes, the services that they need are critically important to their overall care, and missing those services can lead to poor outcomes. Coordination and integration is an effort to maximize support and minimize conflicts that undermine progress. And then in this area, again, training has resulted in improved communication between child mental health and child welfare staff providers. TIC training has resulted in positive effects on staff perceptions of the service environment with differences based on hierarchy. So understanding how services are received in a particular agency. Trauma-informed trained supervisors report more collaboration within and outside their agencies with improved staff morale, fewer negative events, and more effective services. And what organizations can do, develop procedures and practices that promote communication with all stakeholders, develop collaborative relationships with outside community agencies, oftentimes providing trauma-informed care training to those outside community agencies, especially for behavioral health providers, can be very, have a high impact. And then as part of the routine assessment process, identifying the community entities that the client interacts with in significant ways, understanding what are those other service systems, the social service systems, educational service systems, the healthcare system, understanding who else they interact with, and with client consent, reaching out to those other services. And then there's also research. I'm going to jump ahead, but there is research demonstrating the cost effectiveness of trauma-informed services. And so I won't go into this in detail, but we are seeing, and there is some evidence to suggest that there's cost effectiveness for society, as well as for individual programs and agencies. And so there's a good amount of research, some research showing that, again, these are cost-effective approaches for organizations, again, as well as society at large. So Tony, I'm going to turn it over to you and let you talk about what organizations can do.
Okay. Well, I hope that we've given you, all of you who say it would really be helpful if we could respond to any of the inquiries that we get about, so, you know, what is it that we know about trauma-informed care, and how can it be helpful, that we've given you, you know, not just a conceptual, but we really delved into any and all research that could strengthen the rationale for the importance of trauma-informed care, and also that you may need to use or could use in your efforts. And so many of you, this is on your agenda for the majority of you out there, which is great. But oftentimes, you know, we don't have sort of the evidence to kind of back up, you know, the expectation that an organization would go forward. So in terms of what's an organization, you know, to do, and you guys are already doing some things, just, I think in communicating for buy-in, I think a lot about this. It's like, so what's the message to an organization or to stakeholders? What's the cost of failing to recognize and address this? You know, it isn't as if we can just ignore, geez, this is not the right time for us. We're not ready to really make much of this trauma-informed care. We're busy with other things. You know, there is really a cost of failing to recognize and address the needs of a population has significant, you know, adversity in its experience. And as we already showed you, the prevalence is really high. So you have incomplete gap, right? Information gap. It's just, you have incomplete information. That is wasteful and potentially harmful. That's what I feel most guilty about in my work when we really didn't do any of this, is that there was information that really we didn't have that could have improved the experience of the person I was working with. You can have misdiagnosis. I'm sure we did that. I'm sure we attributed symptoms and problems associated with trauma, but we said, oh, that's just part of schizophrenia. Oh, that's just part of depression. Or that's just part of anxiety, right? And that's a big problem, misdiagnosis. Disengagement is where the client doesn't feel like you're really connecting with what's really going on, right? If trauma and adversity is really an important factor, and it can result in dropouts, or some might say pushouts, right? And staff performance and turnover is that this is one of those conceptual frameworks that speaks as much to the workforce as it does to those who are served by the workforce. And that is, it's really wasteful, it's mission failure, it's harmful, it's costly when one ignores the impact of work-related stress on the workforce. Next. So you can have the will, but you need also a way. And, you know, so in many ways, there are a number of things organizations can do, is become trauma aware, trauma sensitive, trauma responsive, and trauma informed. and really in some ways what we're saying is, some organizations, they're going to go more transformational. They really want it to become part of the culture of the organization. And others are saying, look, we have to take this one little step at a time in light of our day-to-day sort of realities. And anywhere you begin in terms of, let's see if we can just make all of us aware of what the importance of adversity and how it impacts both the people we serve and those who are providing those services. So let's go to the next slide. Okay, so this is a model that you may want to take a look at for those of you who would like to get a sense of, what the areas of focus, then what you can do, and what's likely to be the outcome in terms of promoting safety and people feeling empowered with a sense of, that my voice matters here, feeling valued and cared for. That's what keeps people connected. So many of you indicated that quality is really the client gets better, meaning that they're successful, that they're moving along with their goals, and that they are committed to the service. And those are the kinds of things that trauma-informed care is looking to accomplish as well. Next slide. So in terms of what organizations, can do, actually, let me just ask you guys, go to the, what would you, if you could just chat in, what is it that you have already done that for those of you said, well, we've done some work in trauma-informed care. Can you just chat in what you've done? Whether it's around workforce development or environmental improvement, or it's, training and education. Can you just kind of like just chat in? So folks are saying they've trained staff wellness and training, fantastic. Training staff, self-assessment, training, waiting room improvement. Okay, that's an environmental, collaborative documentation, training and education, having positive quotes in the office, again, to try to keep the focus on creating an environment that's very positive and wellness focused, training and education. Again, a lot of it is around staff training, right? And that's like really an important place to begin and that you would hope that in your training, that the people who are the recipients of that training say, I'm so glad that our organization cares about this. I'm so glad that we are increasing our awareness, right? And appreciation and sensitivity to the importance of adversity. And then the issue of self-care. There are many organizations I work with, that was a major part of their trauma-informed efforts, is attending to the issues related to the workforce. Thank you so much for sharing that, guys. Next slide.
You know what, Tony, I realize we have short time, so let me check in with Connor. We have a couple of more slides, but we also wanted to make sure, are there questions? Maybe we can take a couple of questions before we end.
Yeah,
and I know we have a couple of more slides to go.
We do have a few questions. So do you want us to just
yeah, please,
can
you share some of those. Can you share some of the questions that have come up?
Yep. And as a reminder to everyone, there is a part 2 of this, so we will get more into this information in the part 2 on October 28th. So one question was, what factors have you found that enable or motivate resilience in some individuals versus others?
Oh, well, that we could do an hour and a half on that one. That's a really important question. We focused intentionally just on the trauma-informed care piece, but there is the other side of the coin, right? Is the area of resilience. So not only to look at adversity and the impact, but also to understand the role of personal strengths and external resources in assisting individuals to not just manage the kind of stresses that they've experienced, but also there may be some growth opportunities, right, that comes out of adversity, which is oftentimes not, appreciated as much. So that's like and there's a whole body of literature, and Jim and I have done a lot of training in this area. So there's no short answer to this, but yes, there are both approaches that look at the external resources and those personal characteristics that are associated with individuals being able to manage and handle, or not getting stuck, which is really the problem. When resiliency fails, the individuals are sort of stuck and not moving along. So I'm glad you raised that. And that's going to be an area that you'll be hearing more from us around the importance of resilience.
And Tony, I would say I agree with you 100%. There's no short answer, but I'm still going to give a short answer. And the short answer is this. And we've done this training where we talk about all the different ways you can think about resilience. But I would tell a program 3 things that you want to focus on. And this is not specific, but if you could focus on safety, we already did that. We talked a lot about safety, right? If you can focus on making your environment as safe as possible, that's number 1. Number 2 that we didn't talk about is self-regulation, right? Creating opportunities, both training your staff and training everyone in your organization to promote self-regulation, to help people sort of regulate their emotion. Again, for the obvious reason, people who've been exposed to trauma have oftentimes have a difficult time regulating their emotions, and thinking broadly about that, not just what clinicians are doing to help promote self-regulation, but what everyone can do in an organization. And the last one is connections. So a lot when we talk about the importance of the clinical relationship, but not only the clinical relationship, but the relationship with everyone in an organization, promoting connections for folks who've been exposed to trauma becomes so critically important in their lives. So if you could just do 3 things: promote safety, promote self-regulation among everybody in the organization, as well as relationships and connections, you're going a long way to promote resilience.
Well, I'm not going to be outdone by you, Jim, in terms of a short answer. So here's my short answer. Be obsessed with the strengths of your clients. Be as obsessed with identifying what's going well in their lives, the things that they've accomplished, any strength that you observe, no matter how small. Be as obsessed with that as you are with identifying problems. I was very problem focused in a lot of my work, and there were so many strengths that simply I completely ignored. And I think that if we're going to talk about one thing one can do on the resiliency side, is to really, in fact, you may have one session with your client. The next session you have, you may ask the client if it's okay to just discuss strengths, what's going well, what's going right, things that interests, skills, knowledge, all of those things that are part of a human being, and not just the issues and problems that bring them into treatment. So let's just, we're pretty much out of time. So let me turn it over to Connor to just tell us about next trainings.
Yeah, so this was part 1 of a 2-part series. So we do have part 2 on October 28th at the same time. That's from 12 to 1:30 p.m. And that will be a panel discussion. So you'll have a chance to hear from various leaders in various organizations about how they've implemented trauma-informed care in their organization and how it's added value. Did you want to say anything else about that, Jim?
No, very quickly. I realized we did skip over a couple of slides. We may do a little introduction on some of those things that organizational leaders can do within their organization. So we realized we did that, but yes, we can add that as a little kind of precursor to the panel discussion.
Yeah, and also you would have been automatically registered for part 2 when you registered for part 1. So you should already have your Zoom link for that and everything. And then we have a few other events that are coming up in October. So we have a webinar on complex trauma this Thursday. And then on October 14th, we have an interactive workshop on schools as racialized spaces. So you'll actually have a chance to discuss with other participants in small groups during that. So we're excited about that. And then we have a webinar on October 19th about identifying and treating self-harming behaviors among youth using technology and social media. So you can register for any of these events on our website, ctacny.org. And you'll also find the recording of today's webinar along with the slides and the resources that we discussed on the website as well. So that should be posted in the next couple of days. So we would really appreciate if you could just take a moment to complete the brief feedback survey that will pop up when the webinar closes. The link is also in the chat box right now. And we'd love to hear what you thought about today's presentation and any other topics you're interested in seeing us cover. And if you have any questions or comments, please reach out to us via email at ctac.info@nyu.edu. We got a lot of great questions today that we didn't have time to address. So hopefully most of you can join us for part 2 and maybe we can get into some of that then. You can also just send us your questions to the email address. So once again, thank you so much for joining us today. And we really hope that you have a great rest of your day. And thank you, Jim and Tony, for a fantastic presentation.
Thank you, everyone.
All right. Best to everyone. Stay well. Bye-bye.